You're at the cutting edge of RNA therapeutics. I'm John Cook, professor and chair of the Department of Cardiovascular Sciences and the director of our new Center for RNA Therapeutics. And we have a wonderful show planned for you today. And my faculty member, Dr. Christopher Brannon, who's an assistant professor in our Center for RNA Therapeutics, will introduce our colleagues.
Thanks, John. It's a pleasure to be here, and today we have with us some junior scientist discussants, Dr. Rajul Ranka, who's a postdoctoral fellow with Dr. Cook's group, and then Alex Liu, who's an MD PhD student also with Dr. Cook's group. And so they'll be joining our panel science discussion following Dr. Lior Zangi's talk. So it's my pleasure to introduce our first invited speaker for these sessions, Dr. Lior Zangi, who is an associate professor of cardiology and genetics and genomics medicine and sciences at the Icahn School of Medicine at Mount Sinai. So Dr. Zangi began his training in experimental and developmental medicine at Hebrew University in Israel before going on to do a PhD in immunology with the Weizmann Institute. And then he went on to do a postdoctoral fellowship in stem cell biology, mRNA therapeutics, and cardiac regeneration at Tel Aviv University, Harvard University, and Harvard Medical School. And so Dr. Zangi's group is now really pioneering work in the use of modified mRNA to treat ischemic heart disease. And so he has a long list of publications, and he was really the first to show that modified mRNA technology can generate cardiac repair after heart attack and prevent heart failure in both small and large animals. And so this work has led to the foundation of 4 biotech startup companies and the filing of 11 modified mRNA-based patent applications, 2 of which have been awarded. And these awarded patents have led to the first phase 2 cardiac modRNA therapeutic clinical trials. And he's recently established a new modRNA technology that's very tissue specific and allows for the minimally invasive delivery of genes to treat cardiovascular disease. So it's my pleasure to introduce Dr. Zangi and welcome him for speaking in our first session.
Thank you very much. Happy to be here.
Thanks, Dr. Zangi, for joining us here at the cutting edge of RNA therapeutics, and you're certainly one of the leaders in this area. But tell us, how did you get to RNA therapeutics? Because I recall that you did a lot of your earlier work was in stem cell therapies for cardiovascular disease.
I always were interested in therapeutics and to develop new therapeutics. And in the early years, when I started to work around 2000, the most hot topic in therapeutics were stem cell biology. And I was sure that this is going to be my path. So I trained for my master and my PhD on stem cell biology using mesenchymal stem cell, hematopoietic stem cells, and others, and trying to induce therapeutics for the blood system, for skin, for bone. When I moved from Israel to Boston to start my postdoc at Harvard, my training was in stem cell aging, how to look at stem cell aging and to prevent stem cell aging with Derek Rossi, who is a world expert in aging of stem cells. And those experiments at that time took a lot of time. It's aging. You need to wait for the cells downstairs for the mice to age. It was not like today that you can already order aged mice. So I said, okay, what am I going to do with all my time? So one of the ideas that there was a small project that Luigi Roren in his lab ran, which was about modified mRNA. He said, look at it, maybe you would be interested in helping him and working on that. And I saw and then I entered into the world of the mRNA therapeutics, understood that basically it allows you to control cells instead of bringing new cells to the body as a therapeutic, like the idea behind stem cell therapeutics. Here you can actually employ and drive progenitor cells in the organ to induce regeneration. So use the body basically as the dish of culturing those stem cells and drive them endogenously into a specific cell type. And that led for the first project, which was to use VEGF-modified mRNA to induce vascular regeneration after myocardial infarction, after heart attack. And that was basically my project. So I forgot about those aging and stem cell treatments and moved to acellular treatment, which was the mRNA therapeutics. That was in 2010.
I remember that paper. That was really a seminal observation that you made, that the introduction of VEGF mRNA into the ischemic heart could enhance angiogenesis and improve cardiac function and restore cardiac function, reduce the injury. That led to a trial that's ongoing. Tell us a little bit about that, how that your discovery in small animal model led to a clinical trial.
So in 2013, we published a paper in Nature Biotechnology in mice showing that this discovery of the VEGF-A have a modest but significant difference, induced a difference of injection fraction and higher injection fraction in a mouse heart when delivered immediately after MI. And then this work were taken by Moderna and AstraZeneca to be evaluated in large animal. And they did this work with Dr. Ken Chen, that was my mentor at the time. And with Ken Chen, they showed that in pigs, when VEGF-A is delivered 1 week after IR, after heart attack, they see an improve of about 5% of the injection fraction. Again, modest, but consistent and significant. And then they have a discussion if to move into human clinical trials, and they went for human clinical trial that was in an arm study. They checked in the arm if the VEGF can induce new vessels, and they have been able to induce new vessels. So that was a very positive result, and there was no significant side effects from direct injection. And then they moved to phase 2 human clinical trials. So the paper, I think 2021, if I remember correctly, was the first phase 1 human clinical trial, and then they moved to phase 2. And I think, no, it was earlier. But the key was that the main phase 2 human clinical trial was part of it during COVID. So it was really have a lot of hurdles in getting those patients to enroll in this study. The study was done in Europe. And in the end, they have a very small amount of patients. But all the patients that receive VEGF-A show an improved injection fraction. So that was the positive side. The negative is, of course, that it's only in open chest surgery because you need the access to the heart. Sadly, they failed to being able to deliver the mRNA through a catheter. That didn't work for them. It's a work that they published with the with a Finnish group, published in Molecular Therapy. And I think that this has led to the limitation that now makes Moderna more hesitated if to move forward with it. The fact that it's working, but it's not really have a huge impact on injection fraction.
Well, nevertheless, I think we learned an awful lot from that work, that from the preclinical development that you were involved in, into all the way into the early clinical trials of VEGF mRNA for heart.
I think there are two major take-home message from this trial. One, there's a clear path. There's a clear path if you want to develop a drug for cardiovascular disease, how to move forward. From 2013, till 2023, 2022, phase 2 human clinical trial. It was like 8 years from injection into mouse until it was injected into human. So I think that was the major take-home message, that it's a very clear path. And two, that it's clinically relevant. People were talking about injecting over 30 micrograms to your arm that can be harmful. Here they injected around 3.5 milligrams into the heart. Mm-hmm. So answering the question how safe it is, and how good is the technology that was developed by Drew Weissman and Carico of the modified mRNA, make it very safe for delivery of genes to the heart.
Yeah, I agree. The safety of messenger RNA and also the speed to the clinic are remarkable attributes of mRNA therapeutics. I just want to mention that you're one of the executives of the new Society for RNA Therapeutics, and maybe in the discussion period we can talk a little bit about the role of the society in helping develop the field. But I don't want to take too much longer because we want to hear your talk. I do want to remind the audience, though, that they can join us in the discussion period. You can go to polev.com if you're on your computer and enter DeBakey and then respond to that activity. Or if you're on your phone, you can just text DeBakey to 37607 and text in your message to us, and that will pop up on our screen above our heads here, and we'll be able to ask your question of Dr. Zangi. But Lior, why don't we go ahead and get started with your talk?
Okay, absolutely. Can you see my screen?
Not yet.
No?
Not yet, Lior.
Okay. Let me know when I know.
So again, while we're waiting for Dr. Zangi's screen to pop up, you can join us in the discussion period by texting DeBakey to 37607 and text in your message. Or you can, if you're online, go to polev.com and enter DeBakey and respond to the activity. While you're bringing that up, Lior, I'll just talk a little bit about our new society for RNA therapeutics. So our Society for RNA Therapeutics is an international society, and we are fortunate to have a wonderful association management corporation helping us with the organization of the society. And we'll talk about the society in the discussion period because it looks like Dr. Zangi now has his presentation up. Lior, please.
Yeah. So thank you, John, for inviting me. I'm really honored to be here and talk to you about the journey that I had since 2010. It's been 13 years. 4.5 years it was at Harvard as an instructor, and then the last 9 years here as independent scientist at Mount Sinai. And most of the work that came from my lab and from my time at Harvard focused on mRNA therapeutics in cardiovascular disease. So the biological question that we worked on was to focus on myocardial infarction, heart attack, which is the blockade of coronary arteries, and after a heart attack, the cardiomyocyte died and are not being replaced by new cardiomyocyte, but rather by fibrosis. And that's basically the fundamental problem, which leads to heart failure, which is the leading cause of death in the world. And the idea that we had was to use a technology that was developed by Carico and Weissman from UPenn, which called modified mRNA. Modified mRNA is an mRNA that the uridine one of the ribonucleotides been replaced by pseudouridine, and this replacement was shown by Carrico and Wiseman to be reducing the activation of the innate immune system, avoiding the recognition and cleavage of the RNAs, and enhance translation via increasing ADS, ribosome complex. So making it really an ideal tool to transiently change the gene expression in the organ, in this case the heart, to move from non-regenerative heart to regenerative heart, to create a windows of regeneration for a short period of time, and then allow the heart to repair itself. The delivery is by direct injection. There's no limitation in the gene size or number of genes. I always say that you need to think about modified mRNA as spices, like pepper, paprika, salt. You can put as many genes that you want, a different amount of every gene. The pharmacokinetic is short. Usually the first 2-3 days is high, but after that it goes down, and it's expressed for about up to 10 days. You can give multiple administration, as we learned in the vaccine. This technology was served the vaccines of Moderna and for BioNTech and Pfizer. So we know that multiple administration is possible. We also know that it doesn't compromise the DNA integrity because we all will have spike proteins in our DNA right now. You can control the expression, so you can decide how much micrograms you want to give from each of those RNA, and you can decide if you want to upregulate the gene or downregulate the gene. You upregulate the gene, of course, by putting the open reading frame, the gene itself, but you also can use downregulation for certain pathways using a dominant negative approach. So you can reduce a certain expression of a gene. But it doesn't have an organ specificity or cell specificity. When the vaccine was injected into your arm, it went to all the cells. We talked about how fast you can move in the clinic. So now I have the presentation in front of me. You can see me in number 1 injecting the mouse heart, and in number 4, a physician 9 years later take the same mod RNA, same type of syringe, and inject human heart. So moving from bench to bedside, I think mRNA is one of the fastest moving tools of gene delivery. We use this technology to find different genes that can induce cardiac regeneration, cardiac protection, and cardiovascular regeneration. The cardiac regeneration we refer on cardiomyocyte proliferation, basically creating new muscle, and those we published with the PKM2 and human FSTL1 mutant, that both of them can induce proliferation of cardiomyocyte and by that repair the heart. We had several publications on cardiac protection. So we have acid amylase that prevent cardiac cell death and inflammation by cutting ceramides, which leading to apoptosis. So by cutting the ceramide, there was less apoptosis, less inflammation. Also PIP4K2C that prevent fibrosis and hypertrophy by inhibiting mTOR and TGF-beta. And we published that dominant negative for IGF-1 receptor can reduce the formation on the epicardium for epicardial fat. So epicardial fat has been activated, this program activated after a heart attack, and by using IGF receptor dominant negative, we prevent the creation of epicardial fat, which is a risk factor in the heart. And last was to use a cocktail of 7 genes that can turn in the heart non-cardiomyocyte cells into mesenchymal stem cell-like, more like stromal cells with pro-androgenic factor secretion that basically leads to cardiovascular regeneration. So reprogramming into more pro-androgenic cells that induce cardiovascular regeneration. So that was basically covering the three areas. Our main gene, the gene that we used the most and we moved forward, you have many success, but I think that the key was the main gene that interested us was PKM2 to induce proliferation of cardiomyocyte. That's work that published in Circulation by Ajit Magadoom, showing that PKM2 is a gene that from glycolysis that induce the pentose-phosphate pathway. This pentose-phosphate pathway is creating anabolic metabolism that induces proliferation. When we inject PKM2 modRNA into the heart, we saw expression up to 8 days, but not more than 12 days. So about 10 days. And we thought if we bring such a strong pro-proliferative gene into the heart, we're going to see proliferation of cardiomyocyte. So when we inject in a mouse model, in a heart attack model, the PKM2 modRNA, we checked after 7 days, and indeed we saw that cardiomyocyte proliferation markers like BRDU, Ki67, PA3, and ORB all significantly being upregulated. So we felt that this is really good. However, also the non-cardiomyocyte proliferate. All the cells proliferate when you give them PKM2. So it's not really what we wanted. We wanted the cardiomyocyte to proliferate. Hence led to the need of having cell-specific with the payload. Just to put everyone on the same page, modified mRNA have a 5' UTR, the open reading frame, the 3' UTRs, and poly-A tail. We inject into the heart naked mRNA. That's also the same technology, the same way that AstraZeneca is doing it for the clinical trials. Injection to the heart is naked. mRNA, in this case modified mRNA, enter into the cells because they have modification of uridine. It's not been recognized by toll-like receptors 7 and 8, and can release and go and be translated to a functional protein in the cells. But that's went to cardiomyocyte and non-cardiomyocyte. So in this case, if it was PKM2, it would be expressed in cardiomyocyte and non-cardiomyocyte, and induce proliferation in cardiomyocyte and also in non-cardiomyocyte. And we want it to be only in cardiomyocyte, not in other cell types. For that, we created a system that we call SMARTS, Specific Modified mRNA Translational System. The SMART is basically a circuit of two mRNAs. One is a suppressor and one is the gene of interest. The gene of interest, again, is GFP, but have a K motif, which is a recognition site for a protein called L7AE. This ribonucleotide protein know how to recognize this K motif, attach to it, and cut it. And basically, if you have those two mRNAs translate in a cells, the L7AE protein going to cut the GFP mRNA, and you're not going to have any translation. However, on the L7AE near the 3' UTR, we put recognition element for MIR1 and MIR28. Those MIR1 and MIR28 are unique by the fact that they express exclusively in cardiomyocyte in the heart. No other cells express those MIRs. So when it comes to cardiomyocyte, this complex, this L7AE, going to be recognized by MIR1 and MIR28, going to be destroyed, and the GFP can translate only in cardiomyocyte. In addition, it's important to emphasize that MIR1 and MIR28 was shown in the work of Deepak Srivastava and Eric Olson before to be detrimental to the heart. So by basically we are sponging two microRNAs that are detrimental to the heart. MIR1 prevent angiogenesis, and MIR28 induce fibrosis. So we reduce microRNAs that are detrimental to the heart and giving a gene that's actually enhancing repair to the heart. So just to show an animation how it works, when this circuit smart system get into non-cardiomyocyte, the L7AE translate the protein recognize the K motif and destroy the mRNA, so you don't have any expression. And when it go into cardiomyocyte, MIR1 and MIR2H recognize L7AE and destroy it. And then the GFP has been translated, and that's exclusively in cardiomyocyte and not in other cell types in the heart, allowing us, if it's PKM2, to have it only in cardiomyocyte and induce proliferation only in cardiomyocyte. Just to have it not in cartoons, in real life, this is a left ventricle of mice stained for troponin I in red, a specific marker for cardiomyocyte, DAPI for the nucleus, and the Cre-activated cells are in green. And when you give Cre mod RNA, you have green cells, which are non-cardiomyocyte, and yellow cells, which are cardiomyocyte. However, when you use our SMART system, in this case we call it cardiomyocyte SMART because it's allowed only in cardiomyocyte. So when you use Cre cardiomyocyte SMART, you see only yellow cells and no green cells. Basically, it's exclusively being translated in cardiomyocyte, and that was published in Circulation in 2020. When we put the PKM2 on this system, on the cardiomyocyte SMART, and we have a 28 days model of MI, so you have a heart attack, you inject the different dilutes or the PKM2 cardiomyocyte SMART, you can see here in the MRI images a clear difference in contractility, which led to much better injection fraction, and the survival over a year was higher. Knowing that this is really a very strong cardiac repair gene, we went, like happened with AstraZeneca and Moderna, into a pig model. Here in the pig model, we basically had using a balloon to create an IR injury, a heart attack, and a week later, modified mRNA was injected into the heart. We used nuclear GFP mod RNA or nuclear GFP cardiomyocyte SMART. And 3 days later, we collected the pigs and we looked using immunostaining for troponin T, and again, specific marker for cardiomyocyte, and nuclear GFP, which is the mod RNA. One can appreciate on the left side that nuclear GFP mod RNA expressed in cardiomyocyte, but also in non-cardiomyocyte. However, when you used nuclear GFP cardiomyocyte SMART, it's exclusively expressed in cardiomyocyte, but not in other cell types. So this is really a clear demonstration that the SMART system works in pigs. Then we moved to the main event. We took 20 pigs. This is a collaboration with Jay Zhang from University of Alabama. We took 20 pigs. We created a heart attack. We waited a week. We used echo to verify that those pigs really had a reduced injection fraction, so they really had an injury. And then we gave 10 pigs with just vehicle, and 10 pigs used the human PKM2 cardiomyocyte SMART. And we follow up for 2 months, which basically is the whole remodeling, using echo and MRI. And what we saw using echo and MRI, that all 10 pigs that received vehicle went to a reduced injection fraction and a heart failure condition with an average of 31.7 injection fraction. However, none of the treated pigs went into reduced injection fraction. 5 of them were borderline, and 5 of them had a normal injection fraction with an average of 50.3 injection fraction. This is a huge difference. The difference happened in the first 10 days. So the PKM2 basically gives a push of proliferation. After 10 days, doesn't change much in the heart and allow the heart to still have much better outcome, probably from secreting other factors like VGF and other androgenic factors. But the majority, the really significant part, was in the first 10 days. So this work, probably one can ask how it compared to the first work that were done on the VGFA. So the VGFA, the work that I published in Nature Biotechnology, shows a 6.8% improvement in injection fraction. However, the delta that Ajit Magadum's work showed was 15.8 with the PKM2. Also, the PIC study that were done by AstraZeneca and Moderna together with Ken Chen shows a 5% increase in injection fraction. However, our work with Jay Zhang showed that 18.6% elevation. So this is much more powerful and potent result. And if the VGF had some improvement in the hearts of patients during the phase 2 human clinical trial, one can only consider what kind of an improvement you're going to see when this will get into the clinic. Of course, we still have to overcome a one major hurdle is how to deliver it, not by using an open chest surgery. And for that, we have two types of approach. I'm going to show you one of them. So work of Keret Kaur and Jamin Yu from my lab asked that today, with the development of nanoparticle, maybe we can create an mRNA that's been delivered instead of direct injected naked, will be IV injected, and will go directly into the heart. And in that case, make it a minimal invasive delivery of mRNA to the heart using a nanoparticle. So we checked different nanoparticles, and we saw that using a cardiomyocyte smart technology, you can get some more specific delivery to the heart and significant reduction in other organs. And this will be used also in a DOX model. The biodistribution is not bad. Without MI, it goes everywhere. You can see here with the CRE being delivered IV. It's in different cells in the heart. When you use it after MI, interestingly, because of the leaky vessel, more of this mRNA has been surrounding the scar tissue. The delivery, the expression starts 10 minutes after injection. So you have, after 10 minutes, you have it delivery into the heart. It's peak after 24 hours. After that, start to decay. And after 3 days, we don't see it get to a basal level. But because it's an IV injection, you can replenish the mRNA by injecting every 3 days. So if you inject every 3 days, you keep the expression in the heart. So we use this technology to treat two different problems in the clinic. One is cardiotoxicity after chemotherapy. So we're talking about the use of doxorubicin that they create a cardiac toxicity. It's a very well-known problem in cancer treatment. So dox is really good to treat for treatment for cancer, but the problem that it's lead to cardiotoxicity. So here, because one would know when he's going to get those chemotherapy, we suggested to give a pre-treatment with this AC. AC is the genes that prevent ceramide, prevent apoptosis. So it's basically protecting the heart. To give a pre-treatment with protecting the heart gene, and only then to give the insult with the doxorubicin. And the classic model is to give 4 injections of doxorubicin. So each time before the injection, we just gave a protective IV injection of LUTs or AC. LUTs is our control gene, and AC is our protective gene. And echo evaluation showed that the one that was not protected and received doxorubicin have a reduced injection fraction and fractioning shortening. However, with the protective genes, we see no differences in compared to control. Also, the alteration in fibrosis, the tissue alteration and creation of fibrosis were seen only in the one that was not protected. So it prevents fibrosis and prevent cardiac function reduction. Another disease that you can treat it with was heart attack. Basically, a classic model that Keret Kaoud from my lab did. The same thing that we thought is that someone have a heart attack, you get into the ambulance, can get an IV injection to condition him to the cath lab. And in this case, we thought about giving a IV injection of, again, of AC is a protective gene to protect the tissue from the ischemic injury. And we give this injection every 3 days and one can see very clearly from the MRI images that the contractility with the AC Smart is better, the scar size is being reduced, and other parameters of a contractility has been significantly higher. But I think here comes the punchline. All what you see, all this repair, happened with a very little amount of mRNA actually gets into the heart. So if you put it in nanoparticles, LNPs, lipid nanoparticles, only 0.02% will get to the heart. If you use our technology that basically do not increase the translation in the heart, but reduce the translation in other organs, the percentage goes to 1.15, but still, it means that 99% goes somewhere else. This is a very inefficient way. Even with such a little delivery, I want to emphasize, you still have a good impact. But there's a lot of work to do. So one of the things that we're working now in collaboration with a company that have a nanoparticle called NLC, which in our hand shows that it increased to 4.6 the modern RNA delivery and almost 12% with the cardiomyocyte Smart. That start to be more normal, at least 10% of your RNA goes. And now we're trying to add to it peptide or antibodies or anything that might enhance it and lead to close to 50%, because I think that's really the number. If you lose 50% of your product, maybe that's okay. But this is what we're trying to improve now, really, to delivery, because while we see an effect, a significant effect, that could be much better. I think it's very similar to the story with the VEGF. The VEGF was just one gene that can do some good to the heart. But if you study carefully and you put effort in it, you can find something that works much better. And my goal is something that can go above 50% to the heart, and that's make much more sense to me. Just a small shift that work, as I mentioned, we work with a company called RNA that Dr. Patrick Sonchiong is the CEO of this company. And Dr. Sonchiong really focus in his research is cancer. So while he was very excited with the smart system and the targeting of the heart, he asked me a very simple question: can you target cancer cells? Because that could be really exciting if you can inject IV and that goes only to the tumor. So I said, I think theoretically it's going to be even easier. And then he asked me, why do you think it's going to be easier? I said, first of all the nanoparticle use PEG. The reason PEG was introduced was, one, to prevent clotting of the nanoparticle, but another reason was to prevent it from getting into the heart. So the heart was probably the hardest target to use. And tumor have leaky vessels inside of them. So I think it will be much easier target to leaky vessel, because tumor usually upregulate a lot of VEGF-A. So they're going to have some leaky vessel in the tumor. And another point was the fact that there is a lot of our system built on a specific mirror that express in the tumor. And because those tumors are built from developmental programming, it's going to have a unique signature that in the adult body we don't have it. So I told him that might work, and he sent us to give it a try. So we chose breast cancer because there's a very nice and very strong model of syngeneic triple negative breast cancer, a mouse model of 41 cells in bulb C mice, and that's it's a very aggressive cancer, and it will be a good target for us to identify. We found different mirrors. So the first thing that we have done, we're creating this circuit with different mirrors that we found from the literature and from our screen, and we then compare it with mod RNA. So when you take mod RNA and you inject it to the tumor, you can see here the circle on the left, it's the tumor. This is the leg, the skeletal muscle. When you inject mod RNA to both of them, you have expression in both of them. But when you use breast cancer smart, and it doesn't matter 1, 2, 3, 4, and you inject to the tumor and to the leg, the translation is only in the tumor and not in the leg. So that was like indirect injection. Then we moved to the next phase, which was the IV injection. So here we took we made a nanoparticle, we inject IV. It went mostly to the tumor. It reduced in other organs significantly. The biodistribution, again, it's in green here, it's nuclear GFP. So you can see very nicely, like around 30% of the tumor has been covered after one injection. Translation is immediately after like 10 minutes, goes up for 1 day, and then start to go down. And every 3 days, you can give an injection and replenish the mRNA in the heart. The number that I'm at least happy with, but it is what it is the 8.3% that actually go to the tumor. The other mRNA just go to other organs. So what you're going to upregulate in the heart, as I mentioned before, we have a gene called PIP4K2C that we showed before in the heart that can inhibit mTOR and TGF-beta. And inhibiting mTOR and TGF-beta, it's also something good for cancer. So we decided to use that. And one of the nice things of using mod RNA in general, you can create your own antibodies. If you have the light chain and the heavy chain, you just put it on mRNA, and then any cells, doesn't matter if it's HEK cell, epithelial cells, or the tumor cells, all of them can introduce a functional antibody, IgG antibody. And when you give it IV, it stays for like up to 25 days, which is the classic behavior of IgG antibody. So we can create an antibody, and of course we choose a checkpoint inhibitor antibody, anti-CTLA4, and then you have a checkpoint antibody that's going to be released, and you have in the tumor the PIP4K2C that's going to reduce mTOR and TGF-beta, and we think that together it can be a good combination. And this is the experiment we've done. We put the tumor in. 4 days later, we start with an IV injection. We did 5 injections. One can see here in pig a significant reduction in tumor volume, in tumor weight, without a significant toxicity for this treatment. So as a summary of my talk, I think that we have used the cardiomyocyte smart in direct injection, and we have a publication showing a skeletal muscle injection that express only in the skeletal muscle. But I think the future will be a minimal invasive delivery, that you put it in a specific nanoparticles and that it can target different genes. There are 3 organs that it's very easy to target, which is the lung, liver, and spleen. Those you can get above 90% easy. And that's it. That's where it's at. After those 3, it's all dropped below 1%, and then you need really to find the one that works and to enhance it. And that's exactly what we are focusing on. So we have one project on the lung, which again, give a lung smart is relatively easy, but we're trying to target only a specific subpopulation in the lung. And we have for breast cancer, we hope to have for different type of cancers, like lung cancer and other pancreatic cancer. It will be very interesting if we can target them with IV injection. And of course, our heart, which is our bread and butter of the lab that we are focusing on. And we hopefully get progress and improvement in those to develop new ones and to improve the ones that are currently being used in the lab. And that's it. That's my talk.
Well, thank you very much, Dr. Zengi. That was very exciting work, beautiful talk, and I'd like to open up the Q&A session. I have a few questions, but I wanted to give Raju and Alex a chance, so if you have any questions to get started, fire away.
Hello, Dr. Zengi. That was a beautiful work, incredible presentation, beautiful animations and images. I just loved it. So I have a question that you said that PKM2 reduced MI in the sense that improved ejection fraction and fractional shortening. But does this effect last, or it's just transient improvement?
This is a last improvement because, as I showed, we tested it in mouse for over a year, and in a pig for over 2 months. And usually remodeling after a heart attack is usually 1 month after the heart attack. Usually you get where you are is where you are. So 2 months is more than enough to say that this is something that it's lasting. The difference, the big jump in the differences between the two groups happened in the first 10 days. So basically, and that's emphasized that the intervention, that the expression of the PKM2 actually was the major key of and the major impact. So you have a very strong impact in the first 10 days, and then it can continue forward. So I think I think it's also probably changed the other cells in the environment. It's not they are not the same cells as they were before. Don't forget those cells been proliferate, something that they're not naturally doing, only doing development. And cardiomyocyte when proliferate, inducing a lot of angiogenic factors themselves to allow them to have blood vessels and to have energy. So I think that this is part of the changes that happens afterward.
So I have a question about payload choice, I guess, for the intervention. So it seems like you've tried a panel. Like, would VEGF improve with CM Smarts if you try to deliver it more specifically? And then, AC, PKM2, and now cyclin-dependent kinase 2. How do you choose the payload? Is it context specific? And then have you ever thought about maybe multiplexing them? Would there be an advantage to sort of stacking the payloads? And what's the upper limit for doing that, I guess?
Absolutely. I think that each of those payload was to evaluate a different approach. So one was to create cardiac regeneration per se, and for us it's to create muscle. So you need to induce proliferation of cardiomyocyte. You cannot go around it. You cannot create muscle without inducing muscle proliferation. So that was genes that induce proliferation. Then I have used genes that doing cardiac protection, basically preventing the death of cardiomyocyte in a heart attack, or preventing fibrosis, preventing more processes that are not directly involved with the muscle. And last was to really vascularization. So each of them were good for a certain a problem or for to overcome an issue. So for instance, PKM2 induce proliferation, but this is more dangerous gene than AC, which just to prevent apoptosis. Because if you prevent apoptosis in your body for 10 days, I don't think it's going to have a huge side effect. However, if you induce proliferation, maybe you want it to induce only in a specific cell type, because in other cell types that can be dangerous. So the how you target it and what you use is very important. Now, when I will have a minimal invasive system that can target the heart in more specific way, then maybe using genes like PKM2 in a minimal invasive will make more sense and will be less dangerous. I think that the key will be really to have a decision what kind of disease you're treating and how. So for instance, with the docs, so doxorubicin leads to apoptosis. So preventing apoptosis makes a lot of sense. To induce proliferation of cardiomyocyte, less makes sense with this kind of disease. Now, regarding the combination of genes, one of the wonderful things with, as I said, with proliferation of cardiomyocyte, that they also induce a lot of angiogenic factors. So that could be a very important key that made you not need to use the VEGF or other angiogenic factor together with it. So I'm not sure about combination. I think that one of the major problem of using combination, that even if they have some additive effect, the problem will be how to get it into the clinic. So the combination has like two problems. One, in papers, it always makes a mess because you need to show in every gene what happened. So usually we want to use one gene and shows what he's doing in paper. And when you go to the clinic, again, they will tell you, okay, you need to put each one of them as individual and all of them together. And that's make it much more complex. Mm-hmm. So I think that in that sense, until the regulatory will change this approach, it will be hard to make a treatment with number of genes, and much easier to go with one target, one strong target that maybe can make a lot of that work.
Makes sense. Okay, so one more question about sort of the minimally invasive systemic delivery. So I was kind of confused. You know, the biodistribution by luminescence looked very specific when you're just looking at the organs themselves, but then the pie charts were kind of discordant with that, where you see maybe 8 to 12%. Is the other 90% luminescence in other organs that you're seeing? Is that like?
Absolutely. So just that you can be able to see indeed that you have expression, each organ have a different scale.
Okay.
So it's a different scale, and of course in the liver you have expression, but it's significantly lower than the liver expression without the smarts.
So I was curious, if you have like 90% in the liver, have you ever thought about putting like a kill switch on the payload mRNA that's like a liver-specific microRNA?
This is all done with that. I didn't want to get into that because
Okay.
it will make it more complex. But of course, the cardiomyocyte smart had many different killing switches
Okay.
for other organs. And the key was to, even with all of them, the fundamental problem is that 0.02% get into the heart. So that's the number you need to start with. Just in comparison, almost any lipid nanoparticle, over 90% go to the liver. There are specific nanoparticles that over 90% go to the lung. So when you start with 90% go to your organ, to make it 100, it's much easier. But when you start with 0.02, you need to do a lot of adjustments until you get into those good percentage. And that's the problem that we're dealing right now. This is what we're working right now. And I think the moment we can overcome that, that will make it very feasible technology to be used. And the other thing that we are doing in collaboration is to try to use with Muhammad Tamir from Houston, actually, from Baylor University, to deliver the smarts using a catheter. And I think that will be another jump in the technology, because the moment we show that it can work in mouse and in pigs, and you can deliver it in a cath lab directly to the myocardium, that will make it an ideal tool for treating the heart and overcome all the other problems that you have. And then with minimal invasive, the moment we get to a healthy amount of percentage going to the heart and not to the other organs, that could be an additional things that you can give for treatment, especially for before chemotherapy. That leads that about 9% of people that get chemotherapy, especially doxorubicin, got into cardiotoxicity. And that could be a very helpful treatment for people. So that's really the vision for the future.
And so I guess I'll just give Alex Liu one chance to ask any questions before we end.
Yeah, Dr. Zengi, fantastic talk. Your work is really interesting and has spanned over 10 years, and you've explored lots of different targets to help heal the heart after ischemic injury. My question to go off Dr. Brandon's question about multiplexing is that, there's different strategies to treat ischemic heart disease. And, you found targets to revascularize the heart, to remuscularize the heart, also to protect the heart. And I imagine these different processes probably have varying therapeutic windows. So I know that mRNA technology is limited in how long it can be dosed for. And I know I was just wondering that has anyone looked at using self-amplifying mRNAs in the space of cardiovascular disease? Is that something that you're interested in?
I have tried before. In 2012 or 13, there was a paper coming from Stanford showing that the Yamanaka factors using those self-amplifying RNA. I've tried to build something like that in the lab. My work with a self-amplifying RNA led to the conclusion that it's too strong. You basically create an alpha virus that gives you a very high expression, but the cells not necessarily can handle such a high expression. And at least in my hand, a lot of them died. And because cells die, and we're talking about the heart, you do not want cell death in the heart. This is not a regenerative organ. You cannot have, you need the least invasive or least toxic delivery method. And I think there is no dispute that modified mRNA is less toxic, lead to less cell death. So my fear was that although it can give a very high expression, it can also kill cells, and I don't want to pay the price of killing those tissues. But that's, again, the way I saw it. I also think that the moment we have a minimal invasive way to deliver RNA specific to organs, it doesn't matter that it expresses only 3 days, 4 days. To give an injection, and again, you can give IV, IP, and just get it into the bloodstream. And that's much easier because then you can control. You have enough regeneration, you want to stop, you just don't inject anymore.
Well, we're at the top of the hour, but a few questions have come in while we've been talking, and maybe you could give like one-sentence responses to the following questions. One is, have you explored, when we think of the heart, we think of the myoblasts, cardiac myocytes, but what about the other cells, the non-myocytes? Have you thought about targeting non-myocytes in the heart with the SMART technology?
Yeah. So the SMART technology, and you can go to the paper that were published in Circulation in 2020, we show that if you put the MIR1 and MIR2A on the gene of interest, then it will never translate in cardiomyocyte, and then it expresses only in non-cardiomyocyte. So if you want to target the non-cardiomyocyte and never have the expression in cardiomyocyte, that's very much feasible. The question is when you want to go to a specific cell type, and many people were interested in getting into endothelial cells or into fibroblasts. We're still interested in getting into endothelial cells specifically, but into fibroblasts, it's really challenging. And I have a PhD student now working on the lung, and we are trying to find the right mirrors that really can allow us to distinguish between those populations.
More to come on that then. Another question that came in was, what about the toxicity of the different LNP formulations? Have you found something that you can give systemically that doesn't have hepatotoxicity, for example?
Yeah, so I think that toxicity happens when it all depends how much RNA you give and how much and what's the frequency. The 3-4 days actually give enough that time for the liver to overcome that toxicity. So we saw some toxicity, but it was not that significant and not that huge, and which lead again that indeed we need the beta nanoparticles. I don't think that the nanoparticles we have today are ideal for this kind of treatment, but for injection every 3-4 days, that's what the treatment we're talking about. For that, it's not that toxic. The liver can overcome that. But I agree with you that this is an issue, and there are some nanoparticles that's safer than others. But I think in the overall, we need to find the right ones that works the best.
Well, thank you. I think we have a few other questions, but I think you've touched on them during the course of our discussion or during your talk. So I think we'll have to say goodbye because we're over the hour. But thank you very much, Dr. Zangi, for a wonderful presentation, really taking mRNA therapeutics from preclinical all the way to the clinic. Quite amazing, and in such a short period of time, relatively speaking. So keep up the great work. Thank you so much for talking to us today. And we look forward to seeing you again soon. Bye now.
Thanks. Bye.
Bye.
Thank you all for joining us at the Cutting